students. Today we're going to talk about joints. Joints are articulations, or functional junctions between bones. Articulation is just a fancy word for joint. Here's a picture of a hip joint. Notice how the femoral head comes up. Got a nice clean line all the way around the outside with no disruptions or breaks down here to the lesser trochanter. Notice that the joint space is fairly even throughout. Now the pelvis isn't magically floating above the femoral head, of course. There's cartilage in here. There's cartilage on the femoral head. There's cartilage inside the acetabulum. And there's a little bit of synovial fluid in there. And that helps to cushion the joint so that the bones don't touch each other. Here's a picture of a little bit of arthritis. You can see that we've lost almost all the joint space up here, so the cartilage is worn away. In addition, do you see how this is kind of coming out here like this? Let's go back one slide. See how the acetabular boundary is fairly nice and even? Go back to here, it's pretty hammered. And if you think that's bad, get a load of this one here. Notice that the femoral head has almost been smushed and kind of mushroomed down a little bit, smushed down to the sides. You also notice that the acetabula itself has grown enormously around this area. This is what we would call a bone spur. This is just an example of Wolff's law in action. As the biomechanics of the system change, as this femoral head starts to move a little bit differently inside of the acetabula, that's going to cause the stress on the bones to be altered a bit. The bones themselves will then start to remodel according to those stresses, and we're going to see loss of joint space and these osteophytes, this spurring that we get. And here's bilateral unhappiness. Femoral heads are pretty hammered on both sides. Here's a normal lateral cervical x-ray. You can see the vertebral bodies here and here and here. And then in between, we've got the cervical discs where there's a little bit of shadow space. Remember, x-rays are stopped by bone, not very well stopped by soft tissue. So there tends to be a little more darkness where we have soft tissues. But you notice there's this nice clean line down the front of the vertebral bodies. There's a nice clean line down the back of the vertebral bodies. And then there's a nice clean line here right on the anterior aspect of the spinal arch. So in between these two lines is where the spinal cord is going to go. Check out this one. Draw our line down this way. Whoops. Look at this. Got some osteophytes here. Look at the joint space here and here and here as compared to here. It's pretty gnarly. Draw the line down this way. It starts to get pretty rough, doesn't it? So this is some arthritis. This is kind of cool here. The soft tissue, you can actually see the epiglottis right here. And then right here we have, I apologize for the blurriness of the photo, but we have some fusion going on. So this is C1 right here. Here's C2, 3, and then 4, 5, and 6 have all been fused together. And because of that, they're not moving normally with each other. And C6 on C7 isn't moving very well. And again, that's caused that altered biomechanics and the application of Wolff's law with the response of calcification. Here's the lumbar spine from the side. It's the lateral view. Nice vertebral bodies, nice even joint spaces in between them. This here's the IVF, or the intervertebral foramina. This is where the spinal nerves exit the spine. And you can see we've got nice big chunky openings here. And over here, let's look at this one. We've got nice vertebral bodies. This joint space is actually okay. The angulation is such that it's kind of overlapping a little bit. That's okay. But let's draw a line down the backs. Look at that. So L5 here has drifted forward on top of S1, on top of the sacrum. So this is called a spondylolisthesis. Spinal cord is going to come right down this way and then have to jink over. Back to the normal one, you can see this is a nice straight shot here without any kind of bumps or detours. So this is going to kind of get the spinal cord to get caught up right in here. And then here's a pretty bad one. Here's some more arthritis of the lumbar spine. You can see we've lost most of the disc space through here. And here's a really, really bad one. Now this is what it looks like grossly. You can see we've lost the intervertebral discs. We've got these huge osteophytes. And it's a little bit hard to tell on x-ray as they kind of come out like this. But these go all the way around the top of the vertebral body, all the way around the bottom of the vertebral body. It's not just kind of one spur that we get off to the side. It goes all the way around like a disc. In fact, this is kind of like a travel coffee mug. Before cup holders, there were travel coffee mugs. If you put your regular coffee mug on the dashboard of your car and went around a corner, because the base of the mug was fairly small, then the cup would tip over very easily and spill hot coffee into your lap. So instead, they made these coffee mugs that had these big flaring bases that would go out, and that gave a lot more stability to the coffee mug. So this is basically what's going on with your body. As these joints have altered biomechanics, the joint complex becomes less stable, and in order to stabilize it, the body's going to throw more calcium at the area, which is going to result in these osteophytic spurs. If this goes on long enough, you'll eventually have a fusion of the vertebral segments. Let's go ahead and classify joints. We can do it in a couple different ways. We're going to start off looking at functional classifications. There are three of them. There's a synarthrosis, an amphiarthrosis, and a diarthrosis. A synarthrosis is an immovable joint. This is where two bones come together, but they really don't move on top of each other. An amphiarthrosis is where the two bones come together and they're going to move a bit. Not a lot, but there's some definitive movement there. And then diarthrotic joints are the ones you're probably used to thinking of. These are the freely movable joints. We can also classify joints by structure. There are fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints have a lot of fibers, a lot of fibrous connective tissue. Cartilaginous joints are going to use either hyaline or fibrocartilage to get the bones to stick together. And then synovial joints are going to use what's called a synovial cavity and a synovial membrane and synovial fluid. Luckily, just as with all of biology, our structure and our function go together. So our structural classification of a fibrous joint is what we are going to use for our synarthroses, our immovable joint. They're held together with little microscopic collagenous fibers, and so the bones really don't have much give. Our cartilaginous joints are all going to be amphiarthroses. So cartilaginous would be the structure, amphiarthrosis would be the function. These are either our fibrocartilaginous discs, like we have in the spine, or hyaline cartilage, like we have in the ribs. And finally, all of our synovial joints are diarthroses. Synovial is the structure, diarthrosis is the function. So let's take a closer look at fibrous joints. There's three kinds of fibrous joints. There's a syndesmosis, a sutural joint, and a gymphosis. A syndesmosis is where we're going to bind two bones together with a ligament or an interosseous membrane. So right here between the tibia and the fibula, we've got a syndesmotic joint. Now, this is almost tacked together, kind of like a sheet of canvas. You can't really pull it apart. If you grab the two bones here and tried to pull them apart, you couldn't do it because of that syndesmosis. On the other hand, it does allow for the bones to be pushed together and to twist a little bit on top of each other. A sutural joint, like we have here in the skull, looks kind of like stitching, and that's where the word suture comes from, is stitches. And then our gomphoses means literally peg in a socket, like the tooth comes down and sits in your tooth socket. And these little tiny microscopic collagenous ligaments are what hold the tooth into your head. Here's our sutural joint again, little tiny collagen fibers holding these joints together. Now, at birth, these joints are more open and movable to allow the baby's head to flex a little bit as it leaves the birth canal. But by about the time a child is 2 years old, these should have pretty much sealed up pretty well. The syndesmosis, here's another example. We've got a little ligament here holding together the fibula and the distal tibia. We also have a syndesmosis between the ulna and the radius. Our gomphoses, as I measured, these little periodontal ligaments here. And when we look at cartilaginous joints, there's 2 types. There's a synchondrosis and a symphysis. A synchondrosis is where we're going to use hyaline cartilage to tie 2 bones together. For example, between the first rib and the sternum, or the manubrium right here, we've got a little bit of hyaline cartilage. We have the same thing down through most of the thorax. All of the ribs, as they come around in the front, are going to transition to hyaline cartilage as they attach to the sternum. And then we have fibrocartilaginous discs in between our vertebrae. There's a fibrocartilaginous disc in the jaw, and what we call the temporomandibular joint, and another one in the pubic symphysis. To backtrack a little bit, our synchondroses is also found in the epiphyseal plate of developing bones. And finally, let's talk about synovial joints. These are classified functionally as a diarthroses. They're complex. They have articular cartilage, which is on the inside to allow them to move on top of each other with less friction. This is hyaline cartilage, by the way. They're encapsulated within a joint cavity and an articular capsule, and there tends to be reinforcing ligaments to help stabilize the joint. Some are within the capsule itself, some are outside of the capsule, and some are inside of the capsule. So these are extracapsular and intracapsular. And then finally, the inside of the capsule is lined with the synovial membrane, which produces synovial fluid. Synovial fluid is extremely slick. In fact, the combination of synovial fluid and articular hyalinic cartilage makes the whole joint complex smoother than Teflon. We can learn some things about synovial fluid if we draw it out of a joint. It helps to lubricate the joint, helps absorb shock, it helps to feed the joint. Hyalinic cartilage is avascular, and it's really, really thin, and the only way it can get its nutrients is through passive diffusion, which is fairly slow. If it was very thick, it wouldn't be able to get nutrients to those underlying areas in enough time to keep it alive. It's very thin, and it actually gets its nutrients from the synovial fluid within the joint. If we draw out synovial fluid and we have some red in it, that indicates blood. So there's some kind of damage going on inside of the joint. If the joint fluid is cloudy, that can indicate an infection. Let's take a look at some of the other structures we find inside a synovial joint. Some joints, such as the knee, will have fibrocartilaginous pads inside of them. These are called meniscus, or menisci is plural. The knee, despite having fibrocartilaginous pads, is classified as a synovial joint because it has a synovial membrane, uses synovial fluid, and has an articular capsule. We also have little bags of synovial membrane. These little sacs of synovial membrane can be found in areas like between the tendons and the bones of some of our joints. This little sac is called a bursa. It's basically just synovial membrane, and it's going to produce synovial fluid. So it's almost like a little water bag. Now I want you to imagine that you take a Ziploc baggie, you fill it half full of water, seal it up, place it on your table, and then you're going to take your textbook and you're going to put it very carefully on top of the bag. The idea is not to pop the bag, but just have the book sit on top of it. Now, as you grab a hold of your book lightly and kind of move it around the table, the bag rolls underneath of it almost like a ball bearing. So that bag is what a bursa is. The bursa rolls underneath things so that the bone and the tendon aren't stressed. If you imagine a rope thrown over a wooden beam, say in a barn, and if you grab the two ends of the rope and go back and forth, you're going to start to fray the rope and you're going to start to wear out on the wooden beam. So instead, you use a pulley. The pulley is attached to the beam, the rope goes through the pulley, and you can sit and move up and down on the rope all day, and all the stress is taken up by the axle of the pulley. So here, as we move the shoulder joint underneath this ligament, instead of the bone wearing at the ligament and the ligament wearing at the bone, all of that stress is taken up by the synovial bursa. A tendinous sheath is just a long, skinny version of a bursa. It wraps around a tendon so that as the tendon moves back and forth, so this long, skinny bursa, this tendinous sheath, is basically just going to travel along with the tendon. So as the tendon pulls down, the tendinous sheath is going to slowly turn inside out, and as it does so, all of the stress of the movement of the tendon is going to be absorbed by the tendinous sheath rather than the tendon or the bone. Because the tendinous sheath, or because the bursa, is made out of epithelial tissue, it has a really high rate of regeneration. The tendon and the bone, being connective tissue, have fairly low rates of regeneration. They both have the tendon has extremely low vascularization. The bone has much better vascularization, but we still don't really want to wear on it. Now, synovial joints are also classified by how they move. And this is determined by the shape of their articulating surfaces. For example, in the top picture here, we have a ball and a cup. And we also have a facet joint. There's facets here that can move around. Now, the ball joint cannot easily go in and out of the socket. The facet joint, you can spin one cube on top of the other. You can translate it in different directions, as indicated by the arrows here, but you can't angle it up very well. So there's several things that stabilize a joint. We've got muscles and tendons that stabilize a joint. If you've looked out in the distance while traveling in the countryside, you'll often see really tall radio antenna towers, and they're held up with guy lines. They help take some of the tension of the tower and help keep it upright. What would happen if one of those popped? Would that weaken the stability of the tower a bit? What if we lost both of them? Which way will the tower now fall? If we push it from the left side toward the right, the wires here are going to lend their stability and the tower is really not going to move. On the other hand, if we push from this side toward the left, there's nothing over here to prevent the tower from falling and it will collapse. Joints are the same way. As long as we have muscles and are reinforcing ligaments surrounding the joint, it's going to limit the movement of the joint and give it stability. If we damage those ligaments, that's when the joint becomes unstable and it starts to have problems. Here's our ball and socket joint. One articulating surface is shaped like a ball and the other has a depression where the ball fits. It is the most movable type of synovial joint. A condyloid joint is where one articulating surface is an oval and it fits into a matching depression on the other articulating surface. It's limited in its motion. It cannot rotate as the ball and socket did. We can do lateral flexion. We can bend it back and forth, but we cannot spin it in place. A gliding joint or facet joint, as you can see, can do some rotation around the axis. It can do gliding or translation in different fashions here, but we can't do any bending to the side. There's no flexion. A hinge joint allows for that flexion, that bending of the joint, but it doesn't allow for translation or rotation. A pivot joint is like it sounds. It can only pivot along its axis. It can't translate It cannot flex. A saddle joint is where the articular surfaces are concave in one axis and convex in the other. This allows for movement in two directions only. So let's look at the knee joint. The knee is a fairly complex synovial joint. Yes, it does have the fibrocartilage, but remember it's a synovial joint. We've got both capsular and extracapsular ligaments to help support it. Over here on the fibular side, we have something called the fibular collateral ligament. And over here on the tibial side, we have the tibial collateral ligament. And just as my example with the radio antenna, if we disrupt this tibial collateral ligament, then there's nothing to prevent the tibia from moving to the left underneath the femur. We're going to assume that the femur, since it's attached to the rest of the mass of the body, is going to remain fairly immobile, whereas the tibia can swing out laterally because this is no longer present. On the other hand, if we disrupted this fibular collateral ligament, then the tibia could flex medially. Because we've got both of them, the tibia tends not to bend side to side. We have some really interesting intracapsular ligaments. These include the ACL and the PCL. The ACL, or the anterior cruciate ligament, is named because it is in the front on the tibia, and it and the posterior make a cross. Cruciate means cross. Cruciferous vegetables have a cross-shaped flower. Crucifixion is being killed on a cross. So cruciate means cross. The anterior cruciate ligament goes from the posterior of the femur and attaches to the anterior tibial plateau, whereas the posterior cruciate ligament attaches more to the anterior medial side of the femur and then comes down and attaches to the posterior of the tibial plateau. If we look at it from the top, we've removed the femur and we're looking straight down in a superior view of the tibial plateau. We have the articular cartilage. This is the hyaline cartilage that the femoral condyles will sit on. Here's our meniscus over here and here. And on the edge of the meniscus is going to be thicker. As we get toward the middle of the tibial plateau, it's going to be thinner, just like the meniscus in a glass of water is thickest on the outside. Now the knee has a whole bunch of bursa. The capsule is reinforced with muscular tendons. The joint capsule is actually fairly thin and is absent on the anterior side. And if the quadriceps tendon is going to give rise to the lateral and medial patellar retinacula and a patellar ligament. Here's our patellar ligament. Here's our medial patellar retinaculum. Here's the lateral patellar retinaculum. Here's our fibular collateral ligament and our tibial collateral ligament. This whole webwork of ligaments and muscles helps to keep the knee stable and limit its motion to one direction only. And then if we open it up inside, take off that patellar quadriceps, or patellar ligament quadriceps tendon, we can see the anterior cruciate ligament. Now, because of the way the anterior cruciate ligament is angled, it prevents the tibia from moving forward underneath of the femur. If this anterior cruciate ligament was gone, there wouldn't be anything to limit that motion, and the tibia would flop back and forth a little bit. But that's enough to start to cause altered joint mechanics and arthritis of the knee. Posterior cruciate ligament prevents the tibia from moving backward underneath the femur. ACL injuries are a lot more common than PCL injuries. Here you can see, I don't know why they have a hockey puck here, but you can see the anterior cruciate ligament being torn right here, as well as the tibial collateral ligament. You can see a little bit of the tear here. This is a arthroscopic view. Here's our posterior cruciate ligament. Here's our anterior cruciate ligament. So you can see if this is intact, just like those stabilizing wires on our radio tower, if you push posterior on the tibia, this is going to limit the motion of the tibia. If we push on the anterior side, then that posterior cruciate ligament is going to limit the posterior motion. If the ACL is disrupted and you push the knee from the back, then the tibia will be allowed to flop forward a good inch or more. In addition to muscles and tendons allowing for stabilization of joints, we also have just the shape of the joint itself. For example, the glenohumeral joint is a ball and socket joint, just as the coxofemoral joint, but the head of the humerus and the glenoid fossa of the scapula articulate together in a much, much more shallow fashion than the head of the femur and the acetabulum. We sacrifice that stability, but that gives us a greater range of motion. Here is the ball and socket of the shoulder. This is the socket here. You can see how very, very shallow it is. And then, of course, the ball of the humerus. This does allow for a lot of freedom of motion, but again, because it's so shallow, it's also very unstable. And the shoulder is the second most dislocated joint in the body. There are several reinforcing ligaments to the shoulder. There's the coracohumeral ligament. There are 3 glenohumeral ligaments. There's the tendon of the long head of the biceps. And importantly, there are 4 special muscles that help hold the humerus onto the shoulder blade. These muscles are called the rotator cuff. There is the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. They're also sometimes called the sits muscles. If you rearrange them a little bit, you get subscapularis, infraspinatus, teres minor, and supraspinatus. These 4 muscles are what hold your arm onto your rib cage. So when somebody tears their rotator cuff, usually it's the infraspinatus muscle because it's the smallest. Here's a medial view of the shoulder. Here's our glenoid cavity. There's a little bit of a lip around here called the glenoid labrum. And then here's part of the articular capsule that we've cut in order to remove the humerus. You can see how very small and shallow that glenoid cavity really is. The elbow joint is pretty interesting. The radius and ulna articulate with the humerus, and it forms a hinge joint, mostly by what's called the trochlear notch of the ulna and the trochlea of the humerus. And if your elbow is working correctly, it only does flexion and extension. So here is the trochlea of the humerus and the trochlear notch of the ulna. It only pivots in one direction. The elbow joint does have a couple ligaments. There's an annular ligament that helps hold the head of the radius in place, and there are 2 capsular ligaments that restrict side-to-side movement. There's the ulnar collateral ligament and the radial collateral ligament, just as we had the tibial and fibular collateral ligaments in the lower leg. Here's the radial collateral ligament and the annular ligament that help hold that radial head in place. The coxal joint or coxofemoral joint is a ball and socket joint. It's much, much deeper than the glenohumeral joint, which is going to limit its motion, but it's going to give it a tremendous amount of stability. Here is our femoral head. You can see the remnants of the epiphyseal plate. This is our epiphyseal line now. Through our spongy bone, we've got trabecula. You can see cortical bone on the outside. And then here's the articular cartilage on the femoral head, the articular cartilage inside of the acetabulum. Joints are fairly easy to name because we just look at the 2 bones on each side of the joint. Ligaments are the same. They're just named for the bone on each side of the ligament, or sometimes the bit of the bone on each side of the ligament. So for example, the iliofemoral ligament is going to go between the ilium of the pelvis and the femur. The pubofemoral ligament is going to go between the pubic bone and the femur. The ischiofemoral ligament is going to go between the ischium and the femur. You can see here's our iliofemoral ligament between the ilium and the femur, and here is our ischiofemoral ligament. On the anterior side, we've got our iliofemoral, and then here's the pubofemoral ligament. The TMJ, or temporomandibular joint, is the most commonly dislocated joint in the body. The mandibular condyles will articulate with the temporal bone. There's two types of movement because of the angulation of the condyles. There's the hinge movement, which allows for depression and elevation of the mandible. And this type of joint also allows a little bit of gliding or side to side. This would be like your cow chewing cud type of motion. So here is the mandible, here's the temporal bone, and the joint between the two would be the temporal mandibular joint. The temporal mandibular joint is a synovial joint. It has synovial membranes. It also has a little bit of an articular disc. This is going to be fibrocartilage in here because we need that resiliency and toughness in the jaw. Here's the lateral excursion or side-to-side movement we get with the jaw. Let's talk about a couple common joint injuries. Dislocations, known medically as luxations, are when bones are forced out of their normal alignment. They're accompanied by sprains, which are damage to ligaments and tendons, and strains, which are damage to muscles. We also have, anytime the body gets damaged, a lot of inflammation going on, and that inflammation can actually immobilize the joint because of all of the swelling. A subluxation is a partial dislocation of a joint. Bursitis would be inflammation of a bursa. Tendinitis would be inflammation of a tendinous sheath. Even though the stress of the joint complex is being taken up by a bursa or a tendinous sheath, we do need to give them time to rest and repair. Arthritis is over 100 different types of inflammatory and degenerative diseases that damage joints. It's the most widespread and crippling disease in the US. Symptoms are most often pain, stiffness, and swelling of the joint, along with loss of range of motion. If the arthritis happens suddenly, what we call acute arthritis, this could be caused by a bacterial infection and is fairly serious. Chronic arthritis that kind of shows up gradually over time and never really goes away comes in a couple different varieties. The ones I want you to know are osteoarthritis, rheumatoid arthritis, and gouty arthritis. Osteoarthritis is the most common type of arthritis. What happens is that the articular cartilage starts to break down. This happens most commonly in the fingers, the neck, the lower back, the hip, the knee. It's a little bit unusual to find it in, say, like the jaw or the shoulder, the elbow, wrists, or ankles, unless those areas have already been injured. Basically, what happens with osteoarthritis is just wear and tear and breakdown of a joint. It's just overuse over decades of use. Osteoarthritis is most commonly found only on one side of the body. So one knee will be affected, or the fingers of one hand will be affected. Signs and symptoms of osteoarthritis would be bone spurs due to overgrowth of bones because of Wolff's Law, pain in a joint during or after use, discomfort in a joint in changes in weather, swelling and stiffness, loss of flexibility. All of these are related to low-grade inflammation. Risk factors for developing osteoarthritis include age, sex or gender more specifically. This happens more commonly in males because they tend to be a little stupider about the things that they do with their bodies. Genetics, injuries, obesity. Everybody knows that the cardiovascular system really takes a pounding with obesity, but the lower limb joints take a tremendous amount of strain from carrying all that extra weight. Having weak quadriceps muscles or any kind of disease that's going to change the structure and function of articular cartilage. Complications of OA include pain. Treatments range from anything from over-the-counter medications to joint replacement surgery. RA, or rheumatoid arthritis, is an autoimmune disease. This is where your white blood cells start to attack the synovial membrane that's found in our synovial joints. RA tends to be bilateral. We find this on both sides of the body. Pain and swelling in the joints, especially in the hands or the feet, aching and stiffness, loss of motion, and because it's involving the immune system, having a fever or low-grade And because it's involving the immune system, fatigue and a low-grade fever are not uncommon. The joints can swell so badly that they'll actually deform over time. Risk factors for RA include age, gender, again, this time it's female, exposure to viruses or bacteria, genetics, or smoking. Complications include, of course, pain, but also depression. It gets to be really difficult when your activities of daily living are severely hindered. For example, just writing or when opening doors becomes horribly painful, that can get really, really depressing. There's adaptations that we can provide, putting handles on doorknobs, modifying pens or spoons, and even things like adapting toilet seats or bath stalls to allow for sufferers of severe RA to lead as normal a life as they can. Treatments for RA are similar to the treatments for osteoarthritis. Interestingly enough, bee venom has been used in China to treat rheumatoid arthritis for about 3,000 years. Obviously not the first choice if you're allergic to bees. Finally, gouty arthritis is caused by uric acid crystals accumulating in the joint causing inflammation. So this is under a microscope here. We've got some uric acid crystals. They're sharp. It's almost like having little shards of glass inside the joint. Typically happens at the first MTP joint, the metatarsal phalangeal joint here. Signs and symptoms include sudden severe attacks of pain and tenderness. Risk factors include genes, lifestyle, medical conditions, medication, age and gender again, this time it's male, and eating excessive amounts of foods with high purine content, such as ice cream, cruciferous vegetables, and oysters. Complications of gout include kidney stones from the buildup of the uric acid crystals in the kidney, and chronic forms can actually deposit crystals underneath the skin. These are called tophi. Interestingly enough, we think T. rex may have had gout. T. rex ate a lot of organ meat, had some big metatarsal phalangeal joints to become inflamed. Treatments for gout include prescriptions and anti-inflammatories and altering your diet. Sprains, as I mentioned earlier, are damage to the ligaments and tendons. There's not a lot of swelling associated with a pure sprain. Weight can be placed on the joint if it's a mild sprain. If it's moderate, we're going to have some swelling. We can have some discoloration. This is from bleeding internally, and the joint can be unsteady when weight is applied to it. A severe sprain is where the tendon has completely disconnected from the joint. The joint becomes very swollen, lots of bleeding, and the joint can no longer bear weight or move properly. Factors that contribute to sprains and strains include poor conditioning or poor technique, fatigue, and improper stretching and warming up. In this first picture here, usually people's feet point in the same direction, and at the bottom is a dislocated knee. When joints are damaged, the best thing to do is use some RICE. RICE stands for rest, ice, compression, and elevation. If it's a mild strain, RICE works. If it's moderate or severe, then you definitely need to involve a doctor.